Today we're going to demonstrate a physical assessment, and when you come into the patient's room, you're going to want to either wash your hands or use a hand sanitizer. Some of the tricks of the trade, we say wash in, wash out, or if there's foam, foam in, foam out. When I first walk into the patient's room, I always look to see that the brake is on, so I make sure that the brake is on the bed. Then I'm going to introduce myself to the patient and do a head-to-toe assessment. Hello, sir. My name is Linda. I'm a registered nurse, and I'm going to do a physical assessment on you today.
Okay.
We're going to identify the patient always with two identifiers, name and birth date. So can you please verify your name for me?
Mitch Mitchell.
And your birth date.
February 29th, 1968.
Very good. That's correct. Let me tell you a little bit about the stethoscopes. There's a couple of different stethoscopes on the market. This is a single tube. You have the diaphragm, and the diaphragm picks up the high-pitched sounds, which you would use for blood pressure, and the normal S1, S2 heart sounds. This stethoscope clicks over, and you have an open bell, and this would be for the low-pitched sounds. Heart murmurs would be something that you would use. My personal stethoscope has only one side, and it's pressure controlled. So if I have it firmly on the chest, it works as a diaphragm. If I hold it lightly on the chest, it works as a bell. Today I'm going to use the two-sided stethoscope. You want to do your assessment from the right side of the patient if possible. The anatomy of the patient sets up best from the right side. When you learn a more in-depth assessment, it's easier to assess the right jugular vein. It's easier to assess the apical pulse from the right side. It's easier to palpate the right kidney. So we're always going to do systematic head to toe. As I ask the client questions, it tells me about his mental status, and I'm going to integrate some of the questions with the assessment. How are you feeling today, sir?
Not bad.
Okay. I'm going to look into your eyes with my light pen. We're looking at the pupils. We're looking to see that they are equal, that they are round, and that they react to light. You want to bring your light pen in quickly from the side, and you'll see that pupil constrict, and his constrict equally. I always like to ask my patient to smile. Can you smile for me? You would be able to pick up any facial drooping. That would give you indication if they had a TIA or a stroke. It also tells you that many of their cranial nerves are intact. As we're moving down, you want to always assess on skin. You do not want to use your stethoscope through a hospital gown. This client is also hairy, so you want to make a very good connection. Now we're going to move to the chest and listen to the heart sounds. We need to have specific anatomical landmarks. So the first one we're going to find is the aortic valve, which can be heard best at the second intercostal space, right sternal border. To find that, you'll find the sternal notch. Move your hand down to where the manubrium bumps up. Directly across is the second rib, and you'll drop down into that second intercostal space. So with the diaphragm, listen for the heart sounds. The normal heart sounds are S1, S2, the lub-dub, and you're deciding is it regular or irregular. Then you'll move over to the pulmonic. You're still at the second intercostal space, but now left sternal border. And listen, is it regular or irregular? Move down into your third intercostal space. We call that Erb's point. It's just a middle point. The fourth and fifth, still on the sternal border, is where you will hear the tricuspid valve the best. And then fifth intercostal space, mid-clavicular line, is where you hear the mitral best. This is also the apical pulse, and you'll want to assess the apical pulse for a full minute. After you listen with the diaphragm, switch it to the bell and go back through that pattern. The bell you're going to hold lightly, back through the progression. Mitral, tricuspid, up to that second intercostal space for the pulmonic, and then the aortic. And so now we'll move to the lungs. With the diaphragm, we're going to start high, because the apices of the lungs do rise above the clavicles. You'll ask your patient to take a deep breath in and out through an open mouth. And then compare side to side. Drop down an interspace. And again. Make sure you're listening for that full exhalation, because sometimes you won't hear a wheeze until the very end of exhalation. We've got 2 more here. And comparing side to side. And then we're going to move off to the side. Deep breath. Comparing other side. And we've got 1 more spot, 1 more time. And compare. We're going to move right down to the abdomen. Are you having any problems with your stomach?
No.
Okay. There's 4 quadrants of the abdomen, and you want to listen to all 4 quadrants. You should be hearing the tinkling and the gurgling, and those are what we call the bowel sounds. And you should hear those in the right upper, left upper, right lower, and left lower quadrants. For you to chart that the client has no bowel sounds, you would need to assess for a full 2 minutes in that right lower quadrant. So he's got bowel sounds times 4 quadrants. We're going to move to his arms. For temperature, always use the back of your hand. It's most sensitive, and his skin is warm and dry. I'm going to check the radial pulse. I like to do mine at the same time. I'm assessing, are they there? And also the quality. Is it weak? Is it strong? And his pulse is strong and regular. From there, I can look at his nail beds. They should be nice and pink. We can check capillary refill, mashing down and releasing. He pinks back up in less than 3 seconds, and that's normal. He also has an IV line in, so this would be a good time to assess the IV site. There should be no redness, no tenderness, and no swelling. We're moving down into the lower body. This client does have a Foley catheter. You would want to make sure that they have a cath secure on. We're going to assess the pulses in the feet. Can you bend your leg for me? On the top is the dorsalis pedis pulse. And I always start in with 3 fingers, and then when I find it, I can narrow it down to 1 or 2 fingers. So he has a nice strong pulse in his foot. There's also a pulse behind the malleolus called the posterior tibial, and he has a nice strong pulse there as well. And I'd want to assess the other. Dorsalis pedis, strong. Posterior tibial is strong. We're going to assess for edema. There's 3 places you'll need to assess for edema. One is on the top of the foot. If you'll press your thumb in for 5 seconds, 1, 2, 3, 4, 5. Then run your hand over it. If there's a little pit, that would tell you there's edema. So there's no edema there. You're going to check on the inside. 1, 2, 3, 4, 5. No edema. And then up on the shin bone. And this client has no edema. We have done this whole assessment on the anterior side of the body. So now I need to ask the patient to sit up, or if the patient was unable to sit up, they could roll over so that you could assess the posterior lungs. So can you sit up for me? The last piece that we'll do is the posterior. We'll be able to listen to the lungs. We would also be able to get a good look at the patient's skin, make sure that there is no breakdown, especially make sure that you look at the buttocks area. So for the posterior chest, there's 7 auscultatory points. So once again, you'll ask your patient to take a deep breath. In and out through an open mouth. Compare side to side. Move down to interspace. Compare. We're going to keep going down to the bases of the lungs, because when fluid starts to build up, it starts to build up in the bases. And you may hear clear lungs until you get down to the bases. And then we've got 2 more spots off to the side. Comparing other side. And our last down here. Comparing other side. And it's done. So we finished our assessment. We were able to do a systematic head-to-toe assessment. It didn't take very much time. You'll want to wash your hands before you move on to the next patient. And the other thing you may want to do is give a little alcohol wipe to your stethoscope before you move on to the next patient. So thank you.